So this is clearly a team effort. You and Ashley in particular has a data team and runs our big data initiative at Stanford. So has done a lot of the initial data analysis. Alan Young, my boss, directs our cardiovascular health clinical program as well. And Alex Pavlovich in particular has taken on the tough job of trying to coordinate all this. And I'll talk a little bit about the background of this, but Y Media is the one who built the app, and then Sage Bionetworks is kind of the data handling piece. They're a nonprofit in Seattle that is handling the data for all the research kit apps that I'll talk about. So we, I guess you could say, drank the Kool-Aid around the idea that if you're going to have a research study based on a phone, that you can really try and reach as many people as possible and really design this as a population health study. Initially in the US, we've expanded to a few other countries. The idea is to be global and to leverage something that the phone can do that relates to prevention and population health, which is look at daily activity and incorporate measures of fitness and other markers or surrogate markers of cardiovascular health. Maybe it's a little bit easier. So, as a background, Research Kit was an effort of Apple. So they supported the development of Research Kit and the initial apps. So they provided the software development help, but otherwise there's been no direct funding beyond that. And the idea was to create a process where studies can happen purely through the phone. So Research Kit is now open source, so anybody can develop a Research Kit-based study, and it has a set of tools that you can put together and tailor to your study, but it includes some fundamental things, the consent process, surveys, and then tasks. So we'll see, as an example, in our study we have a 6-minute walk assessment, so that's one of the tools that's in Research Kit that you can pull into your study. There were 5 apps that were released together. So they included asthma and breast cancer, Parkinson's disease, ours was cardiovascular disease. I think the other key question that always comes up, the data, as you mentioned, goes to Sage Bionetworks. We can go to an anonymized server for analysis and data sharing, and Apple is not on the pathway of the data. And it also leverages HealthKit, which is a function on the phone that aggregates data from a variety of mobile health and potentially EMR, and talk about genomics and other ways to bring in health data into a common repository or aggregator. So kind of the basis of our study was to look at daily activities. We know physical activity overall is beneficial, but it's based largely on survey and, you could argue, aspirational reporting of what people do. So the idea is to have really measured real-world activities and correlate them with markers of cardiovascular health. That the long-term vision is, can we have a more granular and better and more real-world understanding of physical activity promoting cardiovascular health? And I think Jess touched on the phone becomes really an optimal platform of something that someone interacts with multiple times a day. The criticism of mobile health has been, well, does it change behavior just wearing a device or using an app? And that is the fundamental question, and in many ways, mobile or having a point of care of research being on the person as opposed to in the hospital becomes really an ideal platform for studying that and doing the kind of A/B testing or randomized testing that's been missing. We have a ton of apps and devices that are saying that this works, but we don't have more traditional ways or data around randomizing. That's not completely true. Laura Burke's paper finally came out on mobile health benefits related to Life Simple 7 the AHA guidelines. So that just came out a couple weeks ago.
I'm sorry, I'm not familiar with that.
So Laura Burke did a summary of all the kind of mobile connected health related data promoting, what is the evidence of whether it helps change the Life Simple 7. So the 7 are, behavior, smoking cessation, physical activity, smoking cessation, weight, glucose, cholesterol, and I'm missing
Blood pressure.
blood pressure. Thank you.
It's an AHA scientific statement,
Yes.
I believe, yeah.
Yes.
And what did it show? I'm sorry.
I have some other slides I could pull up related to it. I think there were as the way the literature works, the data that was then published, that then there was enough evidence that then got reviewed by a large committee that then took almost a year for review and then publication. A lot of the technologies were text messaging based, but they did show, positive effects on smoking cessation, some studies on weight loss. A lot of the effects were short term, but there were a few studies that showed some longer term benefit. I think it showed that there's promise there, but there's still a lot of work to do. And what's hard is a lot of the devices used then aren't even made anymore. Obviously, text messaging can still be done, but the technology has changed underlying it. But I can, for later, if that comes up, I can try to put a little bit more into that. But the idea is you can design a study that incorporates surveys, consent, and then different tasks. So our focus is on capturing activity data, a 6-minute walk fitness assessment as a marker of cardiovascular health, and we have them input the data for ASCVD risk score, both as feedback and as markers of risk. And then the initial part is looking for kind of cross-sectional and forward-looking changes in activity, fitness, risk factors. Outcomes becomes more challenging beyond these surrogate markers. And then, as I mentioned, A/B testing of behavioral interventions, which is, we're working with the Heart Association right now to incorporate some of their digital health tools and Life Simple 7 guidance into a behavioral intervention piece. I think what's most relevant for almost any study you're thinking of doing as part of a study design is that it greatly lowers the barrier for letting people know about a study and finding out about it and enrolling in it. So, you can literally go to the App Store on the iPhone and search My Heart Counts, and it pops up, and you can download it. And then it has informational screens about eligibility and what's involved. And then it has, there we go. A whole app-based consent process. So kind of all the key features that a consent form will review are presented as separate screens. One could argue that it may be even more informative than getting a 2 or 3 or 5 or 8-page document where you mostly jump to the end and sign. So the user can take their own time, they can look at it, they'll learn more, they'll expand on each section, but at the end they will still get the official consent form. So, and the way our hospital, our IRB works, the PI's name, so my name's on all these, 50,000 consent forms but that are delivered basically through the phone, and then if you agree and your email matches, then that goes to you via email and PDF. So I think the ability to do enrollment and consent, and again, depends on really the level of risk of your study. Any study where you're going to do a test that has a significant risk, or you're talking about a drug or an implanted device, you obviously need to see the person and have that face-to-face, but the ability to reach a much larger pool of people, to learn about the study and see if they're eligible, that I think is a potential benefit for most any study you're thinking about. I mentioned HealthKit. HealthKit's not perfect, but it does have a number of data fields that can come in from other wearable devices or connected devices around glucose, blood pressure, physical activity, and hopefully that will continue to evolve. You can set up a schedule of tasks. Those can be surveys or different interactive tasks. And then this whole issue of what's the best way to engage the user. So there's a dashboard, we can get some feedback. There's a learn section, they can learn more about the disease or review any of the documents that they've signed. But this trade-off of providing information and giving feedback to keep someone engaged and yet not have that be too much of a behavioral intervention. You know, I think there's a push-pull around that issue. But this is something where you really do need people who understand anthropology and behavioral motivation. And I think there have been a couple of articles and research papers in JAMA on behavioral economics. The guy from Penn who's done a number of things in that. So there's a whole element to this that goes beyond what we mostly learn in medical school. So at this stage, we have over 45,000 have enrolled and consented. As you can see with many things, there was this big publicity event when they all got launched in March, and so the downloads drops off. So the issues of how to keep people engaged and how to have them come back. Importantly, we realize people aren't going to do this every day, so we do a 1-week assessment where we ask them to be good about keeping their phone with them and answering the surveys and doing the fitness assessment, and then revisit on an every 3-month basis rather than trying to make this a continuous activity. So Ewan's group has looked at, you can break people up into these nice groups of people who spend a lot of time in their car, people who are very sedentary, the weekend warriors, mostly exercise on the weekends versus daily exercisers. And it's already seen some interesting patterns. People who are the couch potato group emotionally is doing the least well compared to the both weekend warriors and the joggers actually are both mentally or emotionally in the best state. And I think we've also where to go? There, sorry. We've effectively built kind of one of the largest 6-minute walk databases there is, and what's important about that is, you know, the big challenge is, do you try to validate your method against the standard? That would be optimal, but you also have to realize, can what a population does in the real world ever really match exactly what you would do if it was a supervised activity in the hospital? And they're unlikely to match. So probably part of our goal is to build up data around what is the normal distribution in a real world assessment, at the same time as trying to get an understanding of how that compares to the traditional hospital-based assessment. But it's unlikely they're going to be exactly the same. So I know Jeff Bolgan's was on the list of potentially coming. I'm not an expert on the Healthy Heart study. I've participated in it. It's very easy. You can Google Healthy Heart. It's been based a bit more around the website. They have a Google website and collects a lot of background history data. And there we go. And I think it's an interesting model because it has a large pool. I think your note said there are over 30,000.
Yeah, he told me about 30,000.
Yeah, because they partnered with the Heart Association. And I know from my own case, I didn't have much of a background history, but you know, I got sent like an AliveCore device to start recording ECG. And so I think they've used the platform of a large pool of patients and then know some about their history to be able to enroll them in sub-studies that can look at, you know, whether it be arrhythmia detection. And I know, you know, they have projects they presented around looking at social media aspects and trying to understand emotional state, behavior, and how that relates to heart disease. So they've partnered a number of apps and devices to be able to study throughout their population. So, has some similarity, but a somewhat different model. But again, kind of leveraging the power of our connected world to be able to let anybody enroll and create another version of a breaking in type study.
So Mike, did provision of information about their slot change the behavior pattern of the consultators?
So we're only a few months into our.
But they get the information at the same time as they're sending it to you,
Yes.
so they can track. And can you see the trends in their?
Well, so part of it is we primarily are asking them to contribute the data over a 7-day period, where they get some amount of feedback during that time. But I think the idea is really seeing how during that initial assessment, what happens on subsequent, follow-up. So I don't know that we've looked at within the 7 days, is there a major fluctuation? And part of the reason you do 7 days is people have a weekly habit of between work and leisure and other activities that it's hard to look at daily fluctuations, but the goal is to look at what are longer-term patterns of change. So I think the technology is at a point where one of the questions I think you had was around ease of enrollment and cost of enrollment and those kinds of factors that potentially tools like this and keeping, helping with engagement, viewing survey questions easier than potentially mailing or bringing people in. What the right use of this kind of technology versus more traditional measures depends on the individual study. But I think there are a lot of tools that this could offer that might help almost any kind of research study.
A few others, go ahead.
Did I hear you say earlier in regards to the consent form that it was all e-consent and that they didn't talk to a human being, or was there a final episode where they talked to a person?
It's all e-consent. So that has to be, the risk of the study has to be such that, your IRB is comfortable that, right, you're not giving them a drug or implanting a device or other things. So, when you're looking at daily behaviors and there isn't an intervention beyond really more of a behavioral, informational, motivational tools at this stage that can still warrant being done through an e-consent. And the healthy heart is similar. It's all e-consent.
I'm one of those data points, and I tell you, it's such an easy process to get informed consent compared to what we do in clinical trial. So that's a no-brainer for recruitment and informed consent and so on. What I like,
these studies collected outcomes, whether through like linkage with National Death Index or hospitalization databases. For example, California has a large hospitalization database.
Yeah, so we haven't built that in currently. I think there was a big push in a lot of the research kit studies to, and in ours as well, around anonymization and trying to, there's a lot of concern about data and identifiers. And so I think when we've looked at, because HealthKit does have a capability to link to Epic, and as an EMR example, I know there's discussion about trying to link in genomic information to HealthKit. So there are going to be more tools to do that. I think we didn't want to try and tackle all that right at the beginning. I know in the Healthy Heart they've talked about location-aware elements, so that if you're, I think I've heard Jeff present that if your phone sees that you're in a GPS location that matches a medical center or a hospital, and you're there for more than a couple of hours, it'll ping you, are you being admitted to the hospital for something, and get outcomes that way. I think we've very much shied away from looking at text messaging, GPS. There's probably different users are going to be more or less comfortable with how invasive. On the other hand, those can be opt-in, opt-out kinds of things. But that's one of the big issues, very big issues with these kinds of studies, is the opt-in component, right? So right now, it's only that you've heard about it and that you have an iPhone. We're trying to expand to other languages and other phone operating systems, and other parts of the world. But each country has their different rules about that too.
I know there is a push by some ultrasound vendors to actually connect their tools with iPhone and Android platforms instead of having a big machine or even a handheld machine which is dedicated to ultrasound. So now the push is to actually communicate their ultrasound data with iPhone or Android and get the information. So you're talking about the cost of testing cholesterol profile. So do you see this coming, or is it already underway where you could just put your little finger stick and you put it next to a little chip on iPhone and you get your cholesterol profile, and just like you get the glucose from the iLens?
Well, I know that there are a lot of companies that are trying to make wearable devices that can measure electrolytes and other blood components. There's a company like Theranos that came as a Stanford founder, where it's based, on a simple prick that you can get done at Walgreens, Walmart, and I think as you build out, one of the pieces that's been hard is having a good data aggregator, so that all this data, feeds into a central thing that a research study could access. But at the same time, there's a lot of fear about, the more all your data is coming in to something, that the more, risk there is it'll be exposed. So I think all those things are coming, but I haven't seen that isn't something that we've integrated yet. But this idea of consumer-driven or citizen science is here, and how to do it well. It's a big challenge, but I think a big opportunity.
That is a future. I think your study is really one of the pioneers studying this, in the same with Jeff Hogan's study. And hopefully when Jessica's study come out, they'll open way. When I talked to Jeff, again, he offered to give insight before the meeting, just in lieu of his participation. And what I liked about his part is sending these sensing devices. He liked what I'm working on. He said we're actually looking at that because vascular function measurement is really good, comprehensive data. He said, we are open to nest studies like yours in ours. He also said he had discussions with Jessica, and this is really the new world, and we have to look at it. I know when Jim presented his design, was trying to save cost, but it's primarily still looking at the old school way of recruiting and doing this. So do you think in the Stanford study, I call this a Stanford study, which that there is an opportunity? Let's say we got funded. Dan Berman went to his friend Sheldon Adelson, and suddenly, magically, he's cutting a check for $100 million to fund this study. Dan comes to you and says, Mike, let's do it. Can we nest this in your study and recruit for these people, and how long will it take to get those people to go to, let's say, like Uber yourself to the nearest coronary calcium, right, or get Samir's trailer to go to their, Uber to their home, do the test. Can it be done with your group, with your cohort?
Yeah, I think that's definitely possible. I think we would, like many practical things, we probably have to go back and talk to the IRB a little bit. Our IRB has actually been, I think, pretty open to this approach. And, it does, that would involve, we would need a, face-to-face and an additional consent, but the idea of reaching a large pool of individuals who may be interested, and you could, push out an update to the app that, has the eligibility criteria to see, not, because it helps see if people are interested, but also, that eligibility part.
Engagement, eligibility, and this, the truck that Samir has, really is a, easy way to go to people's home. You recruit them by phone, you send a truck there, just like you Uber them, and you monitor them by being attached to them through their phone.
Yeah.
And presumably that should reduce costs significantly versus, the traditional CRO method that,
Yeah, it's funny you bring that up because I usually start off with a slide that when I'm talking mobile health, I'm usually not talking about the big van, coming to deliver your healthcare. But it's actually a really interesting way to think about complementing, if you really move the point of care or research to the home, and some of the things you want to do as part of the research study involve more sophisticated things than you can mail them in an envelope. Then the idea of bringing that to them, that Zahi and Valentin pioneered as part of these studies, is great.
I think some of the screening, the inefficiencies that we see with a lot of standard trials where you manually go and have a checklist of who, and sometimes, we would be the one before you even got to a point that you could invite someone in. I think engaging people and having them be part of that process, that's, to me, a huge place to save costs.
What was it, 37,000 people were screening in Jupiter and
Yeah.
in Europe?
And
There's
68,000.
68, yeah, sorry, something like that.
David, what about the ischemia trial? You probably spent a ton of taxpayer money.
how hard is it to screen?
What's that?
How hard is it to screen?
It's easy to screen because we're screening people in stress labs. There's a very specific location. So, but it's very difficult to recruit because we're recruiting people who have a lot of ischemia. And there's a 50% chance they'll be randomized to a conservative strategy. So they have to have at least, if it's a nuclear stress test, at least 10% ischemia. And in the places where we work, virtually all those people are in the cath lab within 24 hours.
Really?
Yes.
I can't think the last time I sent a patient with 10% perfusion defect in the cath lab.
Yeah, you are the as we know from your presentation, you are the exception.
Those are called discouraged.
Does it have to be 11% or what?
Well, Dan will tell you that this 10% cutoff is based on a point estimate. If you look at the confidence intervals, they overlap to 16 to 20.